It turns out that in psychiatric nursing, what seems like a clear-cut decision, doing good for the patient, often plunges nurses into deep ethical and legal dilemmas, where values, responsibilities, and obligations collide with no obvious right answer.
Really? That's wild. I mean, you'd think it would be straightforward, help the patient, right? But it sounds like it's way more complicated than that.
Exactly. And that's the crux of it. These dilemmas don't just affect patient care, they also impact nurses, well-being, and even their legal safety. So understanding how ethics and law intersect is crucial for navigating these challenges effectively.
Yeah, and I guess by the end of this, we'll have a clearer picture of how ethical theories shape nursing practice, how legal frameworks influence psychiatric care, and how nurses can manage moral distress while still upholding patient rights and safety.
Right. So let's start by unpacking the difference between ethics and law in psychiatric nursing. They're distinct, but often overlapping domains.
Ethics is more about the values and beliefs that guide nursing on multiple levels: individual, professional, and systemic. Whereas law is society's way of codifying values and objectives, providing a framework to protect rights and regulate practice.
Exactly. Take mental health legislation, for example. It defines when involuntary admission and treatment are permissible, balancing individual rights with public safety. Nurses have to navigate both realms, and sometimes those ethical ideals and legal mandates can conflict.
That tension must be tough. So what ethical theories actually underpin nursing ethics?
There are four main ones. First, deontological ethics, which is duty-based. It focuses on rules and obligations. The Canadian Nurses Association's Code of Ethics and Psychiatric Nursing Standards are grounded in this.
And that includes principles like respect for autonomy, non-maleficence, beneficence, and justice, right?
Yes, plus two others. The principle of impossibility, which recognizes limits to obligations, and the principle of fidelity, which is about loyalty and doing your best for the patient.
Then there's consequentialist ethics, or utilitarianism, which focuses on outcomes, maximizing happiness, and minimizing harm for the greatest number.
Right, and virtue ethics emphasizes character traits like compassion, courage, and integrity. The idea is that good people make good decisions.
And finally, relational ethics, which is especially relevant in psychiatric nursing. It focuses on the context and relationships in ethical decision-making, emphasizing mutual respect, engagement, embodied knowledge, interdependence, and uncertainty.
That last one really highlights how power dynamics and vulnerability play into ethical decisions in mental health care.
So nurses are constantly balancing these theories in practice. But what about the real-world dilemmas they face?
Well, nurses often encounter conflicts between principles. For example, autonomy versus beneficence. There's a vignette about a pregnant woman with schizophrenia who wants to carry her baby to term, but her family insists on abortion. Reducing her antipsychotic medication to protect the fetus risks relapse, and there's concern about her ability to care for the child.
That's a perfect example of conflicting ethical principles. Nurses might feel moral distress, knowing the right thing, but being unable to act due to constraints.
Exactly. And there's also moral uncertainty, when nurses aren't even sure what the moral problem is or which principles apply. Repeated exposure to these situations can lead to moral residue, which accumulates and can cause burnout or moral numbing.
But there's hope in moral resilience, the capacity to cope and act ethically despite distress.
Yes, and strategies to develop moral resilience include identifying personal and professional values, engaging in ethical consultations, advocating for resolution, reflecting on emotional reactions, and connecting with colleagues.
Nurses also sometimes face conflicts between their personal values and institutional policies, which brings in conscientious objection. But they still have to ensure patient advocacy and care continuity.
Right. Now, shifting gears to mental health legislation in Canada, it's evolved from custodial, stigmatizing models to frameworks emphasizing human rights, least restrictive care, and autonomy.
All provinces and territories have mental health acts, allowing involuntary admission under strict criteria, balancing autonomy and safety.
The World Health Organization's 10 basic principles guide mental health law globally. These include promotion and prevention, access to care, least restrictive care, self-determination and assistance, review mechanisms, qualified decision makers, and respect for the rule of law.
But there are differences between jurisdictions in when and how rights are overridden for safety. Nurses need to understand their local legislation and its ethical implications.
Absolutely. Now, on autonomy, consent, and capacity, these are foundational. Informed consent is grounded in autonomy and requires understanding without coercion.
And importantly, psychotic symptoms don't automatically mean incapacity. Competency is legally determined, and if a patient is incompetent, a guardian may be appointed.
Nurses also work with implied consent in routine care, but must ensure the patient understands the procedure, risks, and benefits.
The right to refuse treatment is fundamental, but complex in mental health. The Starson versus Swayze case really illustrates this.
Yes, Scott Starson, diagnosed with bipolar disorder with psychosis, refused medication. Courts ruled he was capable to refuse treatment despite his illness.
That case highlights the low threshold for capacity and the tension between respecting autonomy and ensuring beneficence.
And then there are community treatment orders, or CTOs, which mandate treatment in outpatient settings. They raise ethical issues around coercion and power dynamics.
So nurses have to navigate respecting autonomy while ensuring safety, often in a coercive context.
Exactly. Now, involuntary admission criteria typically include the presence of a mental disorder, risk of harm to self or others, or significant deterioration, and potential benefit from treatment.
And a second independent physician, often a psychiatrist, must confirm the admission.
The principle of least restrictive care mandates using the minimal necessary force or treatment. Restraints and seclusion are last resorts with strict contraindications and monitoring requirements.
Chemical restraints, like medications, are generally considered less restrictive than physical restraints, but come with their own ethical concerns.
Right. Nurses have a legal duty of care, including intervening when patient safety is at risk. Failure to intervene or report can lead to liability.
There's a vignette about Nurse Monia, who identifies a dangerous drug interaction between sertraline and phenelzine, and must act despite physician resistance.
That illustrates the duty to intervene, even when it's challenging. Elements of negligence include duty, breach, cause, proximate cause, and damages.
Nurses must follow institutional policies for reporting concerns and escalating issues.
Intentional torts, like assault, battery, and false imprisonment, and unintentional torts, like negligence, are relevant in psychiatric settings.
Reporting impaired colleagues is a legal and ethical obligation, but complicated by stigma and fear.
Confidentiality is a core nursing duty but not absolute. Exceptions include risk of harm to others, child abuse, suicide risk, and communicable diseases.
The Tarasov case established the duty to warn potential victims of threats made by patients.
Nurses must assess and communicate risks of violence appropriately. Failure to report threats or relevant information can be considered substandard care.
Documentation of assessments and communications is critical.
Medical records serve multiple purposes: communication, continuity, legal evidence, and quality assurance.
Accurate, thorough, and timely documentation is essential. Electronic records require strict confidentiality safeguards, including password protection and access controls.
Nurses must be aware of reporting requirements for child abuse, abuse of persons in care, and communicable diseases.
Reporting suspected abuse is a legal duty, with protections for good faith reporters.
Advanced directives allow patients to express treatment preferences in case of incapacity.
Nurses play a key role in educating patients and families about directives, but must avoid conflicts of interest.
Guardianship is a legal mechanism appointing a representative for patients deemed incompetent.
Nurses must identify guardians and collaborate with them in care decisions.
So to wrap up, psychiatric mental health nursing is a complex interplay of ethical principles and legal mandates.
Nurses must balance respect for autonomy with beneficence and safety, often under challenging circumstances.
Understanding ethical theories, mental health legislation, and legal responsibilities is essential for safe, effective practice.
Moral distress is common, but can be mitigated through moral resilience strategies.
Nurses have a duty to advocate for patients, intervene when necessary, maintain confidentiality with exceptions, and document meticulously.
And being familiar with local laws, professional codes, and institutional policies empowers nurses to navigate ethical and legal challenges confidently.
Exactly. It's a tough balance, but with knowledge and support, Nurses can provide care that is both ethical and legally sound.
Yeah, and that's what makes psychiatric nursing such a challenging but vital field.